Okay, everyone. I'm Richard Oehler with the Division of Infectious Disease, and thank you all for coming. Uh, and today I'm going to give you a little bit of an update on MRSA. I've been giving this talk for a couple years. There's another version of it available on our website, IDPodcast.net, for those of you listening at home. And but there's some new issues to talk about MRSA with regard to diagnosis, which I've edited this talk, so I thought I would give it again. But I think it's fair to say that all of us, if we're seeing patients from day to day, deal with MRSA in one form or another. It's one of the most common pathogens that we see every day, one of the most significant pathogens, and one, if it were not present or somehow went away, would have a profound impact on us and our patients. So this update, I think, answers some of those questions. Would you believe that that there could have been mention of Staph aureus in the Bible? Has anyone heard about this? Is anyone familiar with the plagues of Egypt? Yes. So in the plagues of Egypt were 10 plagues that God released upon the Egyptians to allow the Israelites to leave. And as the story goes, the sixth plague, the plague of boils, in this plague, the pestilence was cast upon the Egyptians in the form of a mist that left them with these very profound boils on their body. And it's thought that perhaps this mention of boils could have been one of the first mentions in antiquity of Staph aureus. So Staph aureus may date as far back as the Bible. Sort of an interesting footnote. But more recently, we owe at least the identification of Staph aureus to Sir Alexander Ogston. He was a Scottish surgeon and early advocate of antisepsis who first described it as a bacterial cause of acute suppuration. He named the organism Staphylococcus pyogenes aureus because of its ability to form pus and also its morphology under gram stain. Staphylococcus meaning sort of grape-like. Now, almost as much of an issue as the disease syndromes that Staph aureus causes is our relationship to it with antibiotic resistance. And many of us remember that back at the beginning of the antibiotic era in the 1940s, specifically 1941 when penicillin was introduced, it was thought to be really a wonder drug that could cure almost everything. And really, we know that in the Second World War, penicillin saved many a troop with sepsis, as well as things like syphilis and STDs and so forth. It was really a wonder drug. And because penicillin and sulfonamides were really the only antibiotics we had available, penicillin's use was very widespread. And it really only took 1 or 2 years for resistance to penicillin among Staph aureus to be discovered. It took about 6 years until the rate of penicillin-resistant Staph aureus achieved 25% in hospitals, and the rates of MRSA of penicillin-resistant or basically penicillin-resistant Staph aureus achieved a 25% rate in the community. It took until about the 1960s. Now, we all know that Vancomycin was introduced about 50 years ago, roughly 1956, and we had a little better luck with this compound. It took about 40 years for the first significant resistance to be reported. Methicillin was introduced really as an answer to penicillin-resistant Staph aureus in 1961. and resistance to it developed very quickly, and it took about 25 to 30 years until the rates of MRSA achieved 25% in hospitals, up until, of course, the late 1980s to early 1990s. Now, in this article for which this table was based, Henry Chambers, who's one of the leading clinical researchers in the epidemiology of MRSA, and incidentally, he'll be speaking for us in June here, reported, or projected rather, that it would take 4 to 5 decades for MRSA to achieve a 25% rate in the community. Well, actually, he was a little bit too optimistic because in some parts of the pediatric community, MRSA rates exceed 75% of the strains. So a tremendous conversion of this pathogen to a resistant bug. And we all know that we've seen a progression of MRSA development as a proportion of strains. Really snowball from being far less than 10% in the 1970s to probably an average of 60% of strains now. So this is a very significant pathogen, and one I would say for the last, really the last 5 to 7 years, where we have really needed to think about covering MRSA whenever we suspect Staph aureus. Now, the prevalence of MRSA it's important to remember, is not an issue in every region of the globe. In fact, places like the Netherlands, Canada, for instance, right in our own backyard, have astonishingly low instances of MRSA. Now, why is this? Well, they have really a twofold strategy. Number one is they have a very strict antibiotic utilization policy, where they restrict antibiotic use. And it's particularly, I know there was a program in the Netherlands or in Northern Europe with regard to the use of macrolides in viral respiratory infections. They really try to have a rational antibiotic use policy. And number two is they really very studiously try to cohort patients with resistant pathogens. So if you were an American coming to the Netherlands, for example, and you happen to get in a car wreck or something, and you were, just because of your country of origin and the incidence of MRSA, you might very well be cohorted until you could prove that you were not carrying MRSA. So they are very strict with their cohorting policy, and also we see in Canada, where antibiotic usage policies, I think, are somewhat more strict than ours, that there's been success in limiting MRSA. Now, this was supposed to say MRSA and community-acquired MRSA, and I'm afraid that the computer has chopped it up. But basically, the purpose of this slide is to this is really an alphabet soup, if you can look at it. Is to distinguish between the terms hospital-acquired MRSA and community-acquired MRSA. And it's interesting, Michael Osterholm spoke yesterday at the College of Public Health, and his group at the University of Minnesota was originally responsible for coining the term community-acquired MRSA, and he stated that he now regrets using that term community-acquired MRSA because it's not really in the community anymore. It's everywhere. So there should be a better term for it. Community-acquired MRSA nowadays doesn't fully describe a pathogen that is present not just in the community, but is the prevalent pathogen in the hospital as well. So it's something to keep in mind. So we all know that MRSA is a major cause of suppurative infections, skin and soft tissue, medical devices, osteomyelitis, orthopedic hardware, and what's more, it has a propensity for hematogenous spread, can cause endocarditis, perhaps the leading cause of endocarditis, of course. Staph aureus produces superantigens, which can lead to toxic shock syndromes. We're all familiar with some of the toxic shock syndromes that have been described in the past. Pantin-Valentine leukocidin. These are these toxins sort of overlie the normal sepsis that a bacterium can cause, and sort of add gasoline on the fire. Staph aureus is perhaps the major nosocomial pathogen, and of course we've seen increasing drug resistance, hVISA, VRSA, heterogeneous hVISA, which we'll talk about later, and we've seen all these changes in epidemiology. Now here's some basics about resistance among Staph aureus that all of you should know. The MECA gene is the gene that confers resistance to penicillins and cephalosporins. And MECA is part of the staphylococcal chromosomal cassette MEC, which is called SCC MEC. This is a mobile genetic element that can be transmitted between bacteria. And SCC MEC has been classified into 5 main types based on polymorphisms in its conserved genes. And what is which of the 5 types of SCC MEC is associated with the quote-unquote community-acquired MRSA? Very good. So SCC MEC 4. So that's important to remember. So here in this illustration, we have the MECA gene, and the the MECA gene can combine into SCC MEC via site-specific recombination, and SCC MEC is when it possesses the MECA gene is responsible for producing an altered form of penicillin binding protein called PBP2A, and this mutated form is unique in that it can continue to manufacture cell wall peptidoglycan even when all the receptors are saturated by beta-lactams. So basically, the peptidoglycan production is not interrupted despite the presence of a beta-lactam antibiotic, and so the bacterium continues to survive and is impervious to the effects of beta-lactam antibiotics. And this is really the mechanism by which Staph aureus becomes MRSA and is resistant to beta-lactams. So the traditional Staph aureus, we all know, used to be called healthcare-associated MRSA, and we know this because before the advent of quote-unquote community-acquired Staph aureus, healthcare-associated MRSA, as the name suggests, was always associated with the hospital. So if we saw someone who got admitted, let's say 10 years ago, with a Staph aureus septic arthritis of a hip with a prosthetic joint in place, then we would assume that the patient got the infection at some point while they were in the hospital. Because they may have had risk factors like recent hospitalization, maybe they were a dialysis patient, they were exposed to it that way, they may have been a resident in a long-term care facility. And this strain of Staph aureus was distinct in that it was resistant to a great many types of antibiotics. So not just methicillin, but it might be resistant to quinolones, doxycycline, Septra, and so forth. And that was hospital-acquired MRSA. Well, community-acquired MRSA, the first reports really began in the 1980s, and we saw MRSA occurring outside of the typical hospital pattern in patients without established risk factors. They might have been younger patients, indigenous peoples or ethnic minorities, particularly a lot of skin and soft tissue infections. And there were outbreaks noted among IV drug abusers, people who played close contact sports, people incarcerated in facilities, in the men who have sex with men category, group homes for the disabled as well. So we saw all these outbreaks in these different communities that were not really associated with the hospital. But it was really not until the late 1990s where, especially this very seminal paper by Ruth, I believe it was by Ruth Linfield in the Minnesota Department of Public Health, that identified these 4 pediatric deaths due to a strain of Staph aureus that was very atypical. And so it was really, as we look back, this case report that made us appreciate the impact of community-acquired Staph aureus as a significant pathogen. This first case was a 7-year-old African-American female who was admitted to the hospital with a septic arthritis of the right hip. And she went on to develop very severe suppurative complications, pneumonia and empyema, and died shortly thereafter. And when you look at the antimicrobial susceptibility here, you could see that the bacteria was susceptible to many different antibiotics, just not beta-lactams. That was the difference. And all these cases were similar in that respect, and they were clonally related by pulse field gel electrophoresis. And from this point onward, I think we began to realize and appreciate the impact of community-acquired MRSA. Now, subsequent research, this was an article from 2006, has shown there was a definite pathway in the development of this community-acquired MRSA strain, which we now identify as USA 300, from earlier strains, and we know that it really came from the community. And what happened is you had this community strain of susceptible Staph aureus, which was previously identified as ST8, and what happened was it picked up SCC MEC type 4. Remember, we talked about it before? And then it picked up the Pantin-Valentine leukocidin gene, and then it picked up Staphylococcus enterotoxin types K and Q. And it was really that process by which it developed into this epidemic community-acquired strain, which we identify as USA 300. So whereas hospital-acquired MRSA began in the hospital as a hospital pathogen, community-acquired MRSA strain completely bypassed the hospital. It started in the really susceptible strains in the community, acquired these resistance factors, and then developed into the strain which has really overtaken the hospital now as well. Yes. No, I mean this happened completely outside of the hospital. So it acquired, for example, SCC MEC type 4 it could have acquired it from other bacterium. I'm not as well versed in this, but I do know that there are resistance factors from VRE, for example, which are translated. Right. It may have got it from other bacteria, and then through the acquisition of SCC MEC type 4 and Pantin-Valentine leukocidin and the Staphylococcus enterotoxins, but completely from the community. It had nothing to do with the hospital originally. So, and this slide emphasizes it. So, it arose by introduction of SCC MEC into distinct MSSA lineages. And actually, here's our answer for your question, and I had forgotten about this, but where did the SCC MEC come from? It likely came from coagulase negative staphylococci. Forgive me for my mental lapse earlier. And it's apparent that insertion of SCC MEC, forgive the typo, has occurred on more than 20 occasions. So this has occurred repeatedly. And VRSA has occurred when the VAN-A gene was transmitted from VRE. Yeah, my impression, the question was, how long has this been going on, this translocation or transfer rather of genetic resistant elements? And my impression is that it's not a new phenomenon, but maybe more selective pressure in the community is responsible for the effects of this being more apparent. But I don't think it's new. I think bacteria are trading genetic elements all the time, and in fact, this I would speculate this may be a reason why we have, intrinsically resistant bacteria in the environment, like Acinetobacter, for example, because of the transfer of these genetic elements. Now, McDougall and colleagues in 2003 developed this this typing or idea of lineages of MRSA, and so this national database of pulse field types were categorized rather by different mechanisms of analysis of Staph aureus. The bottom line is they came up with these lineages of MRSA, and the community, there are 11 lineages, USA 100 through 1100, and USA 100 is a synonym for the hospital-acquired strain of Staph aureus, the one that traditionally began in the hospital, that's resistant to many antibiotics, and typically is acquired in the hospital setting. That's USA 100. The community-acquired MRSA lineages were mainly USA 300 and 400. Now, USA 300 is sort of the Tyrannosaurus rex of the group. It has basically started out from this limited geographic area and spread to all parts of the country, and now, as I've said, is likely the predominant pathogen in the hospital as well. So USA 300, and here's the pulse field gel electrophoresis type here, is the predominant strain of community-acquired MRSA. So when the CDC looked at outbreaks around the country and kind of compared them, and remember, there are many outbreaks. Some of you may remember the outbreak that occurred among two NFL teams playing on a stadium with artificial turf, and they developed this community-acquired outbreak among the members of the team. They looked at other sports teams like college football, different prisons with outbreaks, community centers for children. And what do you see here? They're all identical. They're all this USA 300 strain. And what you can also see here is they were distinctly different than the so-called hospital strains, USA 100 and 200. So this is a community-acquired strain, really spreading widely across the country and being responsible for these outbreaks. Now, why is Staph aureus such a fierce pathogen? Why does it preoccupy Dr. Velez's time here, much of the time when she's doing her day-to-day medical care? Well, because, and I don't mean to single Dr. Velez out, all of us in the room, because it has so many virulence factors. I mean, look at all the virulence factors in Staph aureus, and not just the leukocidins, but we look at things like exfoliatin, which is responsible for the desquamation that occurs with Staph aureus, the clumping factor, which, as I've said, is shared by Staph lugdunensis and causes it to, just the presence of that virulence factor causes it to be a significant pathogen for endocarditis and other syndromes. Staphylokinase, toxic shock syndrome, toxin, all these virulence factors contribute to the pathogenicity of Staph aureus. But one to mention rather in community-acquired MRSA is, as we said, is panton-valentine leukocidin. It's really a marker for the pathogenicity of community-acquired MRSA. Subsequent studies have shown it may not be the major virulence factor, but certainly the presence of PVL in an organism is bad news for you if you are infected by it. And it is a characteristic of community-acquired MRSA. More recent genetic analysis techniques, I think, are trying to have a basis for genetic identification of PVL in an organism to facilitate the identification of community-acquired MRSA. If we could, right now it's not as easy to detect PVL in a strain. Yeah. Well, the question was about are there host factors that can increase the likelihood of acquiring a serious Staph aureus infection, and my answer is there may be. I don't know if they're very well characterized, but the thing about this community-acquired Staph aureus strain I think that's notable was even at its outset it was affecting normal healthy people who were exposed to it. So I think it does carry. It carries some of the characteristics of other bacteria and uses it to its advantage. And I don't have this slide in my current talk, but there is a factor that community-acquired Staph aureus carries that it acquired from Staph epi, and basically it's a factor that permits Staph epi to thrive very easily on your skin. We all know that if we cultured our skin right now, we would culture coag-negative Staph probably very readily. But the thing about coag-negative Staph is it doesn't have the virulence. But if you took that factor that allows it to stick to skin and thrive on skin and converted it to a serious pathogen like Staph aureus, then you would have a much more dangerous bug that would be able to stick to skin and probably colonize a bunch of different people. And that's in fact what we have with community-acquired Staph aureus. That's why we see it being easily transmitted on gym equipment, on from one person's sweaty hands to another, and from humans to pets and so forth, and more on that later. So it is a bug that can affect everybody in that respect. Right, and there may. Yeah, I'm sure there are some genetic factors or innate immunity factors there, but I don't know if they're as well characterized. But there are people who, for one reason or another, have through circumstance or medical history or the presence of implanted devices or comorbidities are more likely to be infected. And that is a very good question. Perhaps I didn't give a complete answer, unfortunately. But more on Pantin-Valentine leukocidin, a combination of these two fusion proteins, and that act synergistically, destroys leukocytes by creating lytic pores, has a high mortality, especially in patients who have a PVL positive strain causing necrotizing pneumonia. So for this reason, you'll associate the presence of Pantin-Valentine leukocidin with serious MRSA. Now, these are the so-called 5 C's of transmission. You can write this down and remember: contact, crowding, contamination, compromised skin integrity, and cleanliness. All of these things contribute to the pathogenicity of community-acquired MRSA. So if we have an outbreak in a prison, for example, we look at, are the prisoners in close contact with each other? Is there crowding? Of course there is. Is there contamination of fomites? Are prisoners given towels once a week and they're only washed every 7 days? Is there compromised skin integrity in the people who are affected? We saw that in the NFL football team that basically got abrasions from the artificial turf. The artificial turf was not natural. It was an artificial surface. They abraded themselves, and then they got Staph aureus from the perspiration of other athletes. And cleanliness is very important. Now, a couple years ago here at the VA, we did, when it was easier to conduct surveillance epidemiology, we looked at community-acquired MRSA as a hospital pathogen. And so we over time, in coordination with the lab, we took 45 MRSA isolates and analyzed them. We actually submitted them to a PhD candidate at the Florida Center for Biological Defense, which is affiliated with our division, for testing with pulse field gel electrophoresis. And the characteristics of PFGE I've listed here, but they're really too complicated to mention, but you can read them for your own information. Basically, at that time, we found about 42% of those strains were the USA 300 genotype. And the sources included wounds, osteomyelitis, skin and soft tissue infections, even a gentleman who had an infected penile prosthesis and there was a fatal case of necrotizing fasciitis, which we'll discuss, and actually which a couple of us published in infectious, I believe in Infections in Medicine earlier this year. And only 22% of the specimens were the USA 100 hospital-acquired Staph aureus. So, I mean, this is incredible. There were twice as many USA 300 Staph aureus as there were the hospital strain. Now, if you'd gone back 5 years before, it would have been totally different, I guarantee you. So this is an onslaught of community-acquired MRSA coming into our hospital. What were some other differences? There was a relevance of younger age with the USA 300. And I think that makes sense because if you have a strain that can affect everybody, you're going to naturally hit younger people, whereas the hospital-acquired strain of Staph aureus mostly affected people in the hospital. Most people in the hospital, are more elderly. They may have comorbidities which increase their, or they may have comorbidities that are a factor of their older age. There wasn't really as many differences in gender, but there was a little bit of a shift towards the African American ethnicity among USA 300, but there was not any difference in diabetic patients. Now, what about this fatal case of necrotizing fasciitis? Again, this was a 50-year-old guy who was at our institution receiving dialysis, and during his dialysis treatment, they noted that he had a high fever, 102, with the onset of a left thigh boil. They put him on gadifloxacin at the time, and he did not do well on it, and 4 days later came back in the hospital and basically was afebrile at the time, and had a left posterior thigh with an isolated 7-centimeter area of induration and warmth, a white blood cell count of 15,800. There's a great concern about this patient, so he was sent to the ER and admitted, and he was started empirically on these antibiotics, the azithromycin, because it was felt that he might have a superinfection with right lower lobe pneumonia. So he got a CT of the lower extremity as part of his admission and showed that he had cellulitis, but there was no obvious abscess or osteo in the CT. However, he did not improve after several days of IV therapy, and on day 4 of admission, his white count had gone up. The area appeared to be more fluctuant, and we were consulted, and along with general surgery. General surgery performed a bedside IND, and they got 50 cc's of purulent material for culture. In just that period of time, just a couple of days, this patient had developed a major abscess. And when you look at the susceptibilities, it's easy to see why he did not respond to quinolones. Again, he had a quinolone intermediate Staph aureus, and of course most of us would not use a quinolone for Staph aureus anyway. They're not ideal drugs for staph. So his antibiotic regimen was modified to include linezolid and meropenem, but he did not improve. His wound site worsened the next 3 days. At that time, yeah, his antibiotics were switched to IV shortly after admission, so he did receive the benefit of IV antibiotics after that initial 3 or 4 day period of quinolone. But again, it appeared that antibiotics was not the only answer here. That he also had the development of something that needed surgical intervention. And so when he was taken back to the OR, he actually was found to have a necrotizing fasciitis, and that required an additional debridement on the following day. His white count worsened. He began to improve, but he had kind of a relapse on hospital day 16, was suspected to possibly have an acute pulmonary embolus, although a CT angio was negative. He went on to develop a cardiopulmonary arrest, cardiogenic shock, and he was found to have a tamponade, which unfortunately was never tapped. So we never got confirmation that it was a suppurative pericarditis, and he kind of deteriorated from there, and eventually care was withdrawn, and he expired on hospital day 17. And when we went back and analyzed that strain, this was a USA 300 clonal type, SCC MEC type 4, and Pantin-Valentine leukocidin positive. So, I should say that to my knowledge, this was back in 2005, 2006. This was probably the first confirmed death due to USA 300 Staph aureus in our community, because nobody else was doing this testing at the time. So what did we conclude from this? The community-acquired USA 300 strain has overtaken us and other hospitals in our institution. And if you look at the literature for Staph aureus, USA 300, there was an article published from Grady Hospital several years ago about it being the predominant cause of bacteremia and the predominant cause of skin and soft tissue infections in emergency departments. It really has overtaken our population of Staph aureus. And even though most of the infections you see are skin and soft tissue, you can have a wide variety of infections. Remember, we mentioned infection of a penile prosthesis. We talked about this necrotizing fasciitis in a dialysis patient. There's a wide range of types of infections. And, we can see all of these from just simple furunculosis to prosthetic device infections to endocarditis to toxic shock syndromes. But as I said, most of these are skin and soft tissue infections, furuncles and impetigo. That's typically what you might see in the outpatient setting. I think there is now a growing recognition that spider bites are, at least in Florida, because remember we're out of this endemic area, are usually community-acquired MRSA skin and soft tissue disease. But you still hear of people describing spider bites coming to emergency rooms. And there was an article about this back in 2005 documenting that we're not an endemic area for the brown recluse spider. So I can't say that it never occurs, but typically we need to get away from this idea of an insect exposure and acknowledge that we're dealing with a community-acquired Staph aureus skin and soft tissue disease. This was from the LA Weekly in 2006, and it just shows you the depth to which community-acquired Staph aureus penetrates, all levels of society. This is basically a tent city in the middle of, they call it Skid Row, in the middle of downtown Los Angeles, where people had developed these really profound suppurative infections, which were attributable to very poor cleanliness and hygiene and living conditions. Remember all the 4 or 5 C's of community-acquired MRSA. So this is more and more a phenomenon of urban areas where you see people coming down with these gigantic abscesses and the potential morbidity that they entail. Just some other notable outbreaks from recent years. This is from 2006. This is a association of Staph aureus skin infections among people who used homegrown tattoos. I think there's been an improvement in hygiene among tattoo parlors nowadays. At least the last time I went. No, I'm just kidding. And that's another story. But these were people who were not in licensed tattoo parlors. They utilized, there's a phrase, catgut needles, where they took dried catgut fiber from musical instruments and inkjet printer ink, and actually made their own tattoos. And they came down with skin and soft tissue disease due to Staph aureus. Now, this was not just a tame skin and soft tissue infection. A couple of patients actually were hospitalized. They became bacteremic. These were serious infections as a result of homegrown tattoos. So for those of you who are contemplating, getting inked, go to an established tattoo parlor. Yeah. Now, something important to remember is the great association between community-acquired Staph aureus and renal failure. And those of us who deal with these patients or have colleagues or spouses who are in the nephrology field may recognize the fact that that dialysis patients and patients with end-stage renal disease have look at this, 100-fold higher risk than the general population for invasive MRSA infections. And in fact, you may recall that the case that I presented was a patient who was a dialysis patient. So in these patients with renal failure, end-stage renal disease, we really need to think about the high likelihood, the much higher predisposition for invasive MRSA infections. And in fact, a lot of the cases of resistant, I believe the first documented case of Vancomycin resistant Staph aureus was in a dialysis patient. These patients are exposed to subtherapeutic doses of vancomycin due to the dosing irregularities of renal disease. They frequently have staph infections related to indwelling devices, and they are at high risk. This is a patient that we saw about 3 or 4 years ago who developed what we believe was a community-acquired Staph aureus sinusitis and orbital space infection that developed very shortly, within 2 or 3 days. You can see him here with paralysis of his extraocular muscle movements before the tape quit. And this is him afterwards when fortunately he had rapid surgical decompression of the area and did very well. And but you can see these invasive syndromes with Staph aureus. This is a paper by Francis in CID of 4 cases of Panton Valentine leukocyte positive necrotizing pneumonia due to community-acquired Staph aureus. Many of these patients had profound morbidity. 1 died. 2 out of the remaining 3 patients had bilateral lower extremity limb loss from profound shock. And there have been many cases in the literature of community-acquired MRSA pneumonia. This is a case from our institution of a spontaneous pneumothorax and a community-acquired MRSA infection. I don't believe this was documented with the genetic testing that we did with others. Celebrities like Rosie O'Donnell have written about their exposure with community-acquired staph. I even read or heard in the literature that Michael Jackson was suffering from a MRSA infection of his nose as a result of the many plastic surgeries he's had to his nose. It's compromised the vascular supply, so he at least recently he's had problems with MRSA infections of his nose. So MRSA in pets. This is a big association, one and near to my heart as we are publishing in this area. And this actress from Britain, her name is Jill Moss. It was the first case in Britain of a death of a pet due to confirmed Staph aureus infection, and as a result, she started a nonprofit in Britain called the Bella Moss Foundation, named after Bella, to promote awareness of the relationship between MRSA and pets and human beings. And when I saw this originally, I was inspired by it, and it was one of the reasons why we've pursued doing some publication in this area in the past. But in the process of putting our article together, I actually have now formed a correspondence with her, and she has a lot of initiatives in Britain for, when anyone says MRSA in pets, they think of her in Europe. The problem is she doesn't really have a forum or the funding to do stuff in the U.S., but she has some people in the veterinary field, and as well as myself. So my hope is that we can raise awareness of this in the States, because a lot of people aren't aware of the association. And hopefully look for that article that some of us in the room are contributing to in Lancet ID in the next few months. Now, what about treatment? There's a triad to treatment of staphylococcal infections, especially skin and soft tissue disease. We want to remember this because, as we know from the rest of our practice, antibiotics are not the only answer, right? We know more than perhaps anyone in any other discipline about the limits of our tools. Antibiotics can help, but they're not always the whole answer. So what is the answer for treatment of Staph aureus infections? Well, let's not forget about surgical debridement. Remember what Oehler said, laudable pus must flow. We have to get the pus out. If there's a suppurative infection, we're not going to treat the infection until we incise that cavity and drain out the pus. And that's at the top of the pyramid. What is at the bottom? Culture. We want to know what's growing there. Is this a Staph aureus? Is there Pseudomonas involved as well? Is there another pathogen which is contributing? Is it a strep infection? Because remember, a lot of our oral antibiotics we use to treat staph are not as good strep bugs, or are not as good against strep. And so we want to make sure we know what's going on there. And then antibiotic therapy as well is important. And we'll talk about that in a moment. And prevention of transmission should always be at the center of our approach, because preventing something is always simpler than treating its after effects. So we know that routine treatments for MRSA skin and soft tissue infections, if somebody has a minor infection, Septra is an excellent choice in the setting of sulfa allergy, or if there's issues with Septra. We think about doxycycline or minocycline. Minocycline has perhaps slightly better antistaphylococcal activity than doxycycline, although minocycline may be a little less well tolerated. The incidence of rash is a little better with minocycline. The incidence of a solar rash is perhaps a little less frequent with minocycline, I should say. And clindamycin is also a alternative, although we have to remember about the phenomenon of inducible clindamycin resistance and the potential for diarrhea and Clostridium difficile with this pathogen, but with this antibiotic rather. But in general, it's important to remember that if an abscess is 5 centimeters or less in diameter, studies have shown you just need to drain the pus. So anything you put the patient on in the setting of draining the pus will help. If we're greater than 5 centimeters in diameter, well, that's a more serious infection, and those patients are less likely to do well without antibiotics, without proper antibiotic use. And this is the D-test that I talked about. Again, the D-test looks for inducible resistance to clindamycin, and this is routinely done now with Staph aureus strains, so in our hospital at least. So you'll see that they'll say inducible resistance to clindamycin is present or it's not present. The phenomenon has been, for whatever reason, that USA 300 Staph aureus is not as likely to have inducible clindamycin resistance. So as it turns out, we've seen less of this in recent years. What are our IV therapeutic options? We've listed them here. And vancomycin, our old mainstay for the treatment of MRSA, we remember that it came from a soil sample retrieved from the jungle trails of Borneo, and aren't we lucky we ran across it, because it was the mainstay of treatment for 40 years. And vancomycin was named because it was going to vanquish penicillin-resistant Staph aureus. However, in recent years, the luster has sort of worn off of vancomycin as well. As much as we use it nowadays, still quite a bit, we see issues with the speed of bacterial killing, tissue penetration issues, particularly in pulmonary tissue, the onset of hVISA and VRSA, the issue of heteroresistant MRSA, and what we call the vancomycin susceptibility creep. And this was published by Rhee and colleagues in CID 4 years ago. The idea that the MBCs of vancomycin are slowly increasing, the fact that there's this progressive decreased susceptibility to vancomycin that may be an issue. Now, in recent months, we've several of us have looked at this with regard to testing for MRSA, because we noticed last year that there were more strains that the Vitek 2 system, which Moffitt and we use together, was detecting. More MRSA strains with an MIC of equal to 2. So we wanted to figure out why that was. Is our Staph aureus becoming more resistant, and so forth? And to understand this, it's important that you know that that the susceptibility testing of MRSA in automated lab equipment like Microscan and Vitek 2 varies by the different brand of machine. The Vitek 2 according to Dr. Mollering, is among the most accurate for determination of MICs. But microscan varies, Vitek2 varies. It's been said that when we really want accurate susceptibility testing for MRSA, sometimes we have to resort to other methods such as e-testing. As a result of the creep of vancomycin MICs that I showed in the 2 slides ago, and these issues about susceptibility testing of different testing techniques, from 2006 to 2008, there was a change in the breakpoints for MRSA susceptibility to vancomycin. So what happened? Well, here's what happened. This is these were initially, I think, adopted by NACLS, which became CLSI, or I think CLSI in 2006 and 2007. And then last year, in May of 2008, the FDA approved these breakpoints. So basically, the MICs for susceptibility to vancomycin went from less than or equal to 4 to less than or equal to 2. And again, that occurred because there was this concern about the vancomycin MIC creep going up, and the idea that we wanted to make sure we weren't calling an organism as susceptible when it was really resistant. So now the official susceptibility for vancomycin for MRSA is less than or equal to 2. So in other words, if you have an MIC of 0.5, that's susceptible. If you have an MIC of 1, that's susceptible. If you have an MIC of 2, that's still susceptible. Even though many clinicians feel that if your Staph aureus had an MIC of 2, that you should probably consider another agent. But that's where we are at the present time. So what about heterogeneous VISA? I put this slide together. It's everywhere you don't want to be. My apologies to the VISA people. So heterogeneous VISA has come up into the mix, and what does that mean? Well, heterogeneous VISA is a subpopulation of Staphylococcus aureus strains that are less susceptible to vancomycin, and they may arise spontaneously during therapy, and they have the potential to induce treatment failure for vancomycin. They may be one of the reasons why you may have treated a patient with vancomycin and their bacteremia persists, or they do clinically poorly, they don't seem to recover as quickly. It may be because heterogeneous VISA strains have risen up, become the predominant population in that infection, and the patient has had a therapeutic failure. There aren't for practical purposes, very many good ways to detect heterogeneous VISA, but probably the most clinically applicable way is to do an e-test to vancomycin. So when you do an e-test to vancomycin, you look at the zone of inhibition here, and you may see, and it's not as visible on this slide, but you may see tiny colonies, single colonies within the zone of inhibition of the e-test. And those are heterogeneous VISA strains. Now what happens if you take those strains, you take a loop, you dig it out of the colony, and you put it on a new plate and you plate it out? Will that be VRSA? Well, no, it's funny. It'll actually do exactly the same thing. It'll be susceptible strains just like this with a few resistant colonies within the zone of inhibition. That's just the characteristic of heterogeneous VISA. So detection of heterogeneous VISA is very difficult to detect because up till now most hospitals have not been doing vancomycin e-tests. And it's important to remember that vancomycin e-tests have their own irregularities. And when we started doing vancomycin e-tests here at the VA, we ran into these. One of the irregularities is that the vancomycin e-test is consistently about 1 microgram per milliliter higher than what the machine says. So the lab here started looking at the e-test, and they realized that every e-test was coming back as 2, when the machine was saying it was 0.5 to 0.1. Wasn't an error in the e-test. Actually, it was just the fact that e-tests read about 1 higher. And for that reason, many hospitals no longer do these e-tests after they do the automated result, especially if they have Vitek2. So, and this is also an interpreter-dependent test. So your lab needs to get very experienced at reading them. Now, when we can't use vancomycin, what do we go to? Do we go to daptomycin, for example? Well, let's look at that in more detail. What are some issues here? Because daptomycin has been traditionally one of our antibiotics that we might go to if we think there's resistance. Now remember, the daptomycin breakpoint is for it to be susceptible. This is the only one reported, by the way. There's no intermediate or resistant. Right now, according to NACLS and the authorities, you're susceptible if your MIC is less than or equal to 2. If it's greater than 2, it's resistant. So as a result, when you do an E-test to daptomycin, it's either reported as susceptible or resistant. There's no gray zone. And the only testing method for daptomycin susceptibility that's really in practical use is the daptomycin E-test. However, it's finicky. It requires careful control of calcium concentration for accuracy, and then remember you have no gray zone. It's either sensitive or resistant. So doing an E-test is is kind of a challenge for daptomycin. Also, the exact method of dapto resistance in Staph aureus is not well characterized. We don't really understand it as well. And lastly, we need to remember that daptomycin resistance tends to occur especially in the setting of vancomycin non-susceptible MRSA. So if you already have a non-susceptible MRSA strain, it's going to be more likely to be daptomycin resistant as well. So what does that mean? I mean, can we rely on daptomycin if we have a resistant strain? Well, it's not well known. And then we have to resort to only one testing method, which may have its own peculiarities. So these are all things we need to come in mind. Are there any new answers coming up? Well, I happen to have a authority on telavancin in the room, and my understanding is that there may be some new drugs coming up for the treatment of MRSA, and one of them is telavancin, and as far as I know, that's the one that is most likely to come out the soonest. Isn't that right? Or are we going to be looking at that perhaps in the next couple of months with telavancin? Dalbavancin has kind of had its ins and outs, and we've heard about it for years, but it's still not out, and my understanding is still not in the new drug application stage. Perhaps it's gone back for additional phase 3. Ceftobiprole has been promised to come out. Again, remember this drug may have MRSA and Pseudomonas coverage, has some big advantages there. And the other two, Aridavancin and Icloprim, show some promise but are nowhere near being available for us to use. So perhaps there is a sort of a shining light in our story. Unlike with gram-negative pathogens, at least with gram-positives here, we have other drugs that may be options. Yes? Yeah, I mean, if the question was about other glycopeptides and whether there is likely to have issues of resistance, as we've seen with vancomycin, this is what I'm doing now regularly. I'm just not touching anything, especially in flu season. That's right, exactly. So, yeah, it's hard to say. I mean, I think from what I've heard with telavancin and dalbavancin and the other glycopeptides is perhaps they don't have the identical susceptibility profile of vancomycin. And we see that also with other drugs like carbapenems and other drug classes where different drugs in the same class may have varying susceptibility. So the hope is that where vancomycin may be non-susceptible, then maybe these other glycopeptides will work as well. But again, in closing, I want to touch a little bit about the issue of Staph aureus screening, because we've been exposed to that here in the VA, spent hundreds of thousands of dollars to do preventative, preemptive screening of Staph aureus among patients coming into units and into the hospital. And basically, my examination of the literature in the recent past has suggested that there's a very mixed opinion about that. This is one study which showed that treatment with a decolonization protocol for 7 days did successfully eradicate MRSA colonization in hospitalized patients for at least 3 months, and surveillance was helpful. On the other hand, this study suggested that although there was some benefit in select areas, that this was a very labor-intensive procedure that may not always be warranted as a universal policy. So the jury is still out. It's a very controversial topic, and certainly one that if you make the commitment, you have to extend a profound amount of resources to keep up with the mandate, as we have. So I hope that this has been illuminating. It's a little bit of an update, and there is much more in the horizon in this topic, and I expect that I will do my best to keep up with it, as I know you will. Thank you very much. I'm going to take questions after terminating the talk. Thank you.